Hi everyone. In this video, we'll see briefly the metabolism of vitamin D and we'll see something about the rickets. So, starting with the metabolism of vitamin D, most of the vitamin D synthesizes in our body itself from the 7-dehydrocholesterol that is present in our skin, and in the presence of sunlight, uh, it makes the raw material for the vitamin D. And like very few amount we take from the diet in either from the uh, plants or animals. So, in the raw form, it comes to liver, and with the help of enzyme 25 hydroxylase, it becomes 25 hydroxy vitamin D. And from the liver, then it goes to kidney, and with the help of enzyme 1 alpha hydroxylase, it becomes 125 dihydroxy vitamin D. And this is the active form of vitamin D, and its function is it increases the absorption of calcium, and uh, so it increases the concentration of calcium in our serum. And once the calcium level reaches to its adequate level, then it gives a negative feedback to PTH, and then when PTH gets decreased, the function of 1 alpha hydroxylase and gets decreased at the same time, and the conversion gets stopped. And other factors, they are in a negative feedback loop, is FGF23. It also inhibits the action of 1 alpha hydroxylase. And one more thing, that in granulomatous tissue, phases and lymphocyte, this 1 alpha hydroxylase is also present in these things. So, in any disease in which the granulomatous tissue and macrophage or lymphocyte activity is higher, we see the hypercalcemia. And one more thing, that uh, after making 25 hydroxy vitamin D, instead of if instead of enzyme 1 alpha hydroxylase, if the enzyme 24 hydroxylase alpha hydroxylase will act, it makes the 24-25 dihydroxy vitamin D, that is again inactive form of vitamin D. So, and FGF 23, which inhibits 1 alpha hydroxylase, it stimulates this 24 alpha hydroxylase enzyme, and again the decreased amount of PTH also stimulates this 24 alpha hydroxylase. So now we will see that something about the rickets. So first of all, what is ricket? Ricket is basically the uh, decrease the mineralization of bone, decrease mineralization of bone in skeletally mature patient, and counterpart of the same pathology in the skeletally mature patient is osteomalacia. So rickets is we see in a skeletally immature patient. So what happens when the mineralization is decreased? So it when mineralization is decreased, the bone ends where the growth is taking place. The bone ends will be weak. So with weight bearing, like when the child starts crawling or anything, so when they put weight over their wrist first when in order to crawl, So area, the distal radius and ulna, which makes the wrist with the carpal bones, they become as they are weak due to decreased mineralization. So they become widened, and the cupping will be seen in X-ray of patient of rickets. Flaying and fraying will be seen in the rickets. So now uh, we'll see the types of ricket. So basically, we divide the types of ricket into four broad category. One is nutritional ricket, and vitamin D dependent ricket, and again there are two kinds of vitamin D dependent rickets, and then vitamin D resistant rickets, that is renal tubular acidosis we see in, and other one is renal osteodystrophy. Okay, now how to differentiate between these forms of vitamin D ricket? So one thing is nutritional ricket is due to the deficiency in vitamin D, that we either due to absence of sun exposure or decreased sun exposure, or our dietary source from planet or animal. When in vitamin D resistant ricket, dependent ricket, sorry, there is a either in type 2 there is a end organ resistance, and in type 1 alpha hydroxylase enzyme is deficient, or there is a resistance to the receptor of 1 alpha hydroxylase. And in renal tubular acidosis, it is due to basically decreased phosphorus. So phosphorus will be low. And in renal osteodystrophy, because renal involvement is there, so 125 hydroxy vitamin D will be low. 125 hydroxy vitamin will be low. So we will see one by one. So serum, we will see the serum calcium, serum phosphorus, PTH, alkaline phosphatase, and urine calcium, urine phosphorus. So in nutritional ricket, what we see is alkaline phosphate will be higher in all the forms. So alkaline phosphate will be higher in every types of ricket. And what about PTH? The first response to lower serum calcium is it activates the PTH. So it will be more in nutritional ricket. It will be more in vitamin D dependent rickets of both types. And in renal tubular acidosis, because serum calcium is normal, the whole pathology is due to the lower phosphorus level. So the PTH will be normal. So here characteristically PTH will be normal. And again, in renal osteodystrophy, PTH will be much higher due to its basic pathology. And what about serum calcium? Calcium will be either normal or low in nutritional rickets. It will be low in both type of vitamin D dependent rickets. It will be normal and in renal tubular acidosis, as we have already discussed. And it will be low again in renal osteodystrophy. And same with the phosphorus, it will be mostly normal in nutritional rickets. In vitamin D, it is decreased. Vitamin D dependent rickets, it is decreased. And very characteristically it is decrease in renal osteodystrophy. And again it is increase in it is decrease in renal tubular acidosis, and it is increase in renal osteodystrophy due to the pathology in the kidney. The filtration will be low, so the phosphorus is increased in renal osteodystrophy. Now we'll see two things: urinary calcium and urinary phosphorus. And before that, we take 25 hydroxy vitamin D and 125 hydroxy vitamin D. So they are decreased in nutritional rickets because the vitamin D is low in first place, and in vitamin D dependent rickets because this one is low, 125 hydroxy vitamin D is low, so 25 hydroxy vitamin will be higher. And in type 2, where the end organ insensitivity is there, so both are low high, because the organ at which the vitamin D is acting, they are resistant to its action, so they are much higher in the serum. And in type 1, there is a deficiency of basically 1 alpha hydroxylase enzyme, and not due to its insensitivity. Sorry, I have mentioned insensitivity also earlier in this video only. So it is due to lack of 1 alpha 1 alpha hydroxylase enzyme. And in because renal tubular acidosis, there is no defect in vitamin D metabolism, they are normal. And in renal osteodystrophy, because the pathology lies in the kidney, and 125 hydroxy vitamin D forms in a kidney, so it will be low, and 25 hydroxy vitamin will be high. And again, when we'll see the serum calcium and urine calcium and urine phosphorus level, they will be in a lower side only in nutritional rickets, and there is no much significance of urine calcium and phosphorus in vitamin D dependent rickets. And in vitamin D resistant ricket, that is renal tubular acidosis, urine phosphorus will be much higher. That's why the urinary phosphorus is lower in the serum, because of the high urine uh, phosphate. And urinary calcium is low or normal. And in renal osteodystrophy, urinary phosphorus will be low because there is a low filtration in the kidney in first place, and urinary calcium will be low also. So the important points are that phosphorus is high in renal osteodystrophy, and 125 hydroxy vitamin D is low in vitamin D dependent ricket type 1, and both are much higher in vitamin D dependent rickets type 2. And PTH is normal in renal tubular acidosis. Both the vitamin uh, both the forms of vitamin D are normal. And in nutritional rickets, these are the parameters usually we see. So now coming to the diagnosis part. So we start treating the patient as a nutritional rickets until otherwise it is until proved otherwise. So we will first give patient, if a patient with rickets comes, that we are diagnosed through the lab tests and X-ray finding. So first, what we do is we give 6 lakh international unit of vitamin D plus 400 to 1000 international unit per day for 1 month. This is maintenance dose, and when patient and ask patient to come after 1 month, what we do, we again we do X-ray, alkaline phosphatase, and 25 hydroxy vitamin D. If alkaline phosphatase level is coming to the normal and there is a the finding of improving on the X-ray, and the and 25 hydroxy along with the 125 hydroxy vitamin D, they are coming to their normal level, it means patient is improving, and most diagnosis was nutritional rickets. And then we continue patient this treatment for mostly 3 to 4 months, and we see when the alkaline phosphatase level coming to the normal, and it takes around 3 to 4 months. And if there is no improvement in these investigation, then we do some lab investigations in which serum phosphorus and 25 hydroxy vitamin D, 125 hydroxy vitamin D, and PTH level are done. So now what we will see, we will see that if the phosphorus is high, that was only in the renal osteodystrophy, so we treat it accordingly, and along with the other phosphorus, other tests will suggest this diagnosis. If we will see the phosphorus is low, then there can be three possibility. One is RTA, that is vitamin D resistant rickets, or vitamin D dependent rickets type 2, or there can be vitamin D dependent rickets type 1. So in vitamin D dependent rickets type 1, the 25 hydroxy vitamin D level will be higher and 125 hydroxy vitamin D will be lower. And in vitamin D dependence type of ricket type 2, both will be higher, and both will be normal in renal tubular acidosis. So this is how we can diagnose the type of rickets, and we treat accordingly. And lastly, what you can see in a patient of rickets from the head to toe. In head, you can see frontal bossing, delayed closure of anterior fontanelle, and delayed dentition, and the craniotips. In chest, you can see the pigeon pigeon taste, pigeon chest, and Harrison sulcus you can see, ricketic rosary you can see, and pot belly you can see in the abdomen. In the around the joints you can the enlarged bone ends you can see around the joint, and double malleoli side you can see. So they are the clinical finding that will be present in a patient of rickets if the rickets is long standing. Thank you.